Yes, sir. I'm just going live.
It's live on YouTube now?
It's live, sir.
Very wonderful.
Yes, sir.
Now you can start
Start.
Professor Volker's address.
Okay, sir.
You can ask Dr. Sangeeta to take over.
Yes, I'll introduce the panelist and I'll hand over. Asmita ma'am, the introductory slides, ma'am. Good evening, everyone. So here we are on the first webinar organized by the Epilepsy Disability SIG of WFNR along with the Indian Federation of Neuro Rehabilitation. And it's a very important meeting that we have today that's advancing epilepsy rehabilitation, implementing WHO's Intersectoral Global Action Plan. And we have organized this on this National Epilepsy Day, where it is for us to reflect on the challenges faced by those living with epilepsy, to celebrate the progress made in their care, and to explore the untapped potential of rehabilitation. And rightly so, for this wonderful theme, we have a star cast panel today of faculties who are going to enlighten us on the wonderful talks under the theme of advancing epilepsy rehabilitation, implementing WHO's Intersectoral Global Action Plan. And let me proceed ahead with introduction of the star cast panel that we have today. First, Dr. Volker Homburg, sir, the President of the World Federation of Neurorehabilitation, the Vice President of European Federation of Neurorehabilitation Societies, and is head of the Department of Neurology, Gesundheitszentrum Bad Wimpfen SRH Group. And he has more than 250 peer-reviewed journal publications and many book chapters. His areas of interest includes motor cognitive rehabilitation, digital technologies, pharmacology, neurorehabilitation, and epistemology in neurorehab. Can I have the next slide, ma'am? Next, we welcome Dr. Nirmal Surya, sir, the President of Asia Ocean and Neuro Rehabilitation Society, the President of the Indian Federation of Neuro Rehabilitation, the President of Indian Stroke Association, and the Secretary General of the World Federation of Neuro Rehabilitation. He is the Chairman of Surya Neuro Center, and he has paved the way for neuro rehabilitation in India and across the globe. He is the recipient of the Kenneth Wiste Jr. MD Patient Advocate of the Year, which is a prestigious award awarded by the American Academy of Neurology. And he is also the Mahatma Award winner. And I'm also his proud mentee. We welcome you, sir.
Thank you.
Dr. Abhishek Srivastava, sir, who is the Secretary and Director of the Indian Federation of Neuro Rehabilitation, and he is the Chair of the Neuro Rehab subsection of the Indian Academy of Neurology, Chair of the SIG Multiple Sclerosis World Federation of Neuro Rehabilitation. He is member at large of the Presidium of the World Federation of Neuro Rehabilitation. He has numerous awards and accolades to his name. We welcome Dr. Abhishek Srivastava, sir. Dr. Sangeeta Rawat, ma'am, who is the Honorable Dean of the Seth GSMC and KEM Hospital. She is also the Professor of Neurology, former HOD of Neurology at the same institute. She is currently the Honorable President of the Indian Academy of Neurology, and with over 80 publications with special areas of interest in epilepsy. We welcome you, ma'am, and we are looking forward to your expertise, ma'am. Next slide, please. And Dr. Mayowa Ovolabi, sir, we welcome you, sir. And he is the director of the Center for Genomic and Precision Medicine, College of Medicine, University of Ibadan. and is member presidium at the World Federation of Neurorehabilitation. He's the regional vice president of Sub-Saharan Africa, the WFNR. He's the regional director at the World Hypertension League, foundation co-chair of the African Stroke Organization, and member of board of directors of the World Stroke Organization. He's the board of directors of the World Hypertension League, and he's dean of the Faculty of Clinical Sciences, University of Ibadan. He's honorary consultant neurologist, and he is pioneer WFNR Blossom Specialist Medical Center. We welcome you, sir. Next, we have Dr. Francisco De Leo, who is an epileptologist and researcher at the Epilepsy Unit of the IRCCS Foundation, Neurological Institute Cibesta in Milan, Italy. With extensive research in anatomo-electroclinical correlations in patients with focal epilepsy and impact of surgery and medication on quality of life and psychological well-being, morphometric and functional changes in cortex and subcortical structures in epilepsy, preclinical and clinical characterization of immune-related seizures and epilepsy. We look forward to your expertise, sir. We welcome you, sir. And we have the Dr. R.K. Damija, sir, who is professor of neurology and director at IHBAS. He has more than 120 publications, and his special areas of interest include neurorehabilitation, neuropalliative care, and movement disorders. He is the recipient of the National Award for Science and Technology 2021, 33rd Dr. S. Radhakrishnan National Medical Teacher Award 2017, and Dr. B.C. Bansal and Uma Bansal Oration in Indian Academy of Clinical Medicine 2019. We look forward to your expertise, sir. Thank you for being with us, sir.
Thank you. Thank you.
With the introduction of the StarCast panelists that we have today, we will proceed with the welcome address by Dr. Volker Homburg, sir. Asmita, ma'am. Asmita, ma'am.
Hello, everybody, and welcome to this webinar on advancing epilepsy rehabilitation in relation to the WHO Intersectoral Global Action Plan. Let me say some words in the beginning about the position of WFNR in this field. The WFNR has basically three major pillars. One is to advance research, the second to advance education, and the third to advance the level of clinical practice in neurorehabilitation around the world. We do this in a multidisciplinary, interprofessional way. We have 43 national member societies, over 5,000 individual members, and we certainly represent something about 55,000 or so professionals in this field around the world. So what is the global situation? The WHO claims that 1 in 3 people today are estimated to be living with a health condition that benefits from rehabilitation, and rehabilitation has to be conceived as an essential part of the universal health coverage, along with promotion of good health, prevention of disease, treatment, and palliative care. We come to that. So we are faced with a situation that over 1 billion people in the world live with some form of disability. So rehabilitation is a huge and dramatically big enterprise to do. The question is if the classical ways in which we are doing this are still useful, especially considering the fact that hundreds of millions of people in the world will not have access to this classical form of neurologic rehabilitation we have developed over the years. When we look at the resources, this is just an example, the number of people for every single physician. And you see in Africa, the situation is 3,600 or so. The situation is better in richer countries, in Europe, the Americas, and parts of South Asia, of course, but it's a tremendous gap between what we need and what we have available. We are very happy that the World Health Organization some years ago made a decision to become interested into neurological disorders and epilepsy, and therefore WFNR is certainly happy to support this Intersectoral Global Action Plan. So the vision of this is to promote brain health in a broad scope and addressing, in this respect, neurological disorders in particular. And the goal is to achieve prevention, treatment, and care of epilepsy and other neurological diseases in a much better way than we are conceiving this today. This is planned until 2030 or 2031. Let's have a look at the strategic objectives of this Intersectoral Global Action Plan. It's strengthening governance, it's provision of effective and timely and responsive diagnosis and treatment, implement strategies for promotion and prevention, foster research and innovation, and strengthen, finally, the public health approach to epilepsy. When we look at these individual objectives, it's quite interesting to see that it's a very ambitious program running until 2030 or 2031. For the strategic objective, 75% of countries by the end of this period should have adapted or updated existing national policies. 100% of countries will have at least one functioning awareness campaign, and that goes further. 75% of countries will have included neurological disorders in their universal healthcare program. 80% of countries will provide the essential medicines and basic technologies. You see, this is very ambitious indeed. 80% of countries, only the strategic objective 3, have at least one functioning intersectoral program, and the global targets relevant for prevention and neurological disorders are achieved as defined in this includes defeating meningitis by 2030 as a global roadmap. And another goal is for every newborn, that there is an action plan to end preventable deaths in perinatal medicine. Strategic objectives: 80% of countries routinely collect and report on a core set of indicators. The output of global research on neurological disorders doubles by 2031. And finally, concerning the epilepsy problem in particular, by 2031, countries will have increased service coverage for epilepsy by 50% from the current coverage in 2021, and will have developed or updated legislation with a view to promote and protect the human rights of people with epilepsy by 2031. So you see, this is a very ambitious program. We recently put together some global synergistic actions to improve brain health for human development. And when you look at this, there's an entire list of about 17 different aspects: combating poverty, combating hunger, increase well-being, increase the quality of education, gender equality, and all of this, from good water to good living conditions in the countryside and so forth. All of these elements are directed to increase global brain health. The brain is the best organ we have. It's absolutely essential for us, and we can do as much as we can to improve brain health in a global way. And that very nicely matches with the WHO IGAP problem. When you look at possible elements which have to be addressed to achieve this goal, I think it was Majova Volavi who called that a neurological revolution. I like the term very much. We have global initiatives. We may have key concepts for implementation, as one of the elements of this is holistic health, to look at health in a holistic way. We have biophysical elements and we have psychospiritual elements as well, which have to be brought together in a neat way. So I'm certain that the whole scenery of medicine within the next decade will change dramatically anyway, with better focalized medicine based on biomarkers, going away from just the ordinary group statistical analysis levels. More severe diseases will become treatable, and digital communication and telemedicine will improve the availability of services and techniques. And the question is how neurorehabilitation blends. And I mentioned earlier that we have a dramatic gap between what is needed and what can be achieved by the available resources. In this sense, this element of digital communication may be very helpful to roll out and spread knowledge about skills and procedures in the field in an affordable and easygoing way. So the bad news is that millions of people do not have access to decent rehab services. We have a lot of high-tech options, but they cannot be used everywhere, and sometimes they are not affordable. But we also have good news. We know that reasonable rehabilitation, and that's important to note, is not critically dependent on technology. You can do recent rehabilitation just by person-to-person interaction, eventually augmented by digital aids helping with that. Knowledge about learning and coaching strategies is of high impact, and community and caregiver-based approaches can be widely used. WFNR is running an entire program to improve the quality of community-based and family-based rehabilitation around the world. And I mentioned already, digital communication tools will certainly help us to work better in this direction. They may be helpful for low threshold spread of rehab knowledge and procedures. I'll give you an example. At the moment, WFNR is developing a complete digital representation of a rehabilitation setting, a rehabilitation hospital, if you like, in the digital world and the metaverse, if you like, which is easily accessible, and it is planned in form of a dialogue system, in the sense that the patient, the caregiver, whoever, can approach this and will be guided by artificial intelligence through the system to answer specific questions and to have a look at particular possible possible low-tech training procedures. Let's have a short look at this. This is a metaverse representation, and in this metaverse world, there is a pavilion of the WFNR, of course, and you enter this pavilion, and then people will approach you, and you can ask questions, and you will be guided through the entire world of neurorehabilitation in such a digital form. It's interactive in the sense that by an artificial intelligence system, a patient or a caregiver can ask questions, they will be answered, that they will be shown around to see some particular training activities, for instance. We are in a very advanced stage of this already now, but I expect that by the end of the year, we will have a complete product which can be spread around the world and can be embedded into the endeavors of community and family-based rehabilitation services. So that is all I want to say for today. The next.
Thank you very much, Dr. Volker Homburg, sir, for the wonderful welcome address that sheds light on the eye gap by WHO, and the most importantly showing us the path on how to go forward. And following the wonderful welcome address, we have the talk on the most important part for a developing country is epilepsy rehabilitation in a low resource setting.
One, let Mayowa speak first because his topic will make sense.
Yes,
Let
sir. Epilepsy rehabilitation in low resource settings. Practical solutions that is required for a neurologist and integrating with the primary health care. From the global expert himself, Dr. Mayowa Ovolabi. Over to you, sir.
Yeah, thank you. Thank you very much. Can you see my screen?
Yes, sir, we can, sir.
Thank you. Thank you very much. Thank you so very much. So I'm speaking from the beautiful island of Mauritius. I actually came for another conference at Data Science Initiative Africa. So I took some break to be part of this. But this is something that is really laudable because epilepsy is one of the most common neurological conditions that we have to deal with. So it's important to talk about epilepsy rehabilitation. And I really want to congratulate India for championing this and Neomasuya specifically for championing epilepsy rehabilitation, particularly in low resource settings. I'll be focusing on practical solutions for neurologists and how to integrate into primary health care. So just on preamble, epilepsy accounts for about 4.9% of disability adjusted life year. That was 2016. And is number 7 in the new ranking of DALIs from neurological disorders, which was published. That's based on the GBD 2021. We can see that epilepsy is number 7. That's globally, and in many regions of the world, it's actually number 6 or number 5 in terms of DALIs. Now, there are some key important facts about epilepsy. It's a highly treatable condition, so much so that 70% of people with epilepsy, if they have access to treatment, appropriate treatment, they can actually live a normal seizure-free life. In fact, there's one person that I usually use as an example. Of course, I have so many others. There is somebody who is a very, very high-ranking officer in the Nigerian military, whom nobody knows has seizures. Because for more than 10 years, he's had no seizures because he's on treatment. And he got promoted rapidly, faster than any other person, and visits more than 40 countries in a year. So it's something that can be achieved for most people who have epilepsy. If we do the main things which I'm going to mention, is the most cost-effective of which are included, that's the medications, are included in WHO model list of essential medicines. So if this is implemented, of course, more than 70% of people living with epilepsy will live a near normal life. But the treatment gap is very huge. 75% treatment gap in LMICs, particularly in rural areas compared to urban areas. Now, to deal with this, we'll first of all must understand what epilepsy is all about. To fully characterize epilepsy, we need to have a diagnosis, so to speak, of epilepsy, and that is axis 1 to 5, as proposed by the International League Against Epilepsy. The first one, of course, is the intersectoral, and then second one is epilepsy classification, the usual thing that we know, whether it's focal, generalized, secondarily generalized, and things like that, or whether it's unknown. And then epilepsy syndromes, as epilepsies that are associated with other conditions, or EEG features, or neurodevelopmental challenges. And then epilepsy etiology. For etiology, we need to look at whether it's genetic, structural, metabolic, immune, infectious, or cryptogenic, or idiopathic. And there could be comorbidities. So if we put, and of course, axis 5 is impairment, whether that is causing disability, which is what we are dealing with today, both physical as well as psychological and social disability that needs to be addressed. So across different age groups, there are different causes, which I will not go into details about. But low and middle income countries bear the brunt. 70% of the burden is in low and middle income countries. And this is, you can see the map. And now, in terms of epilepsy-related expenditure, it will surprise you that only about 4% is spent on medical consultation, only about 20% on anti-epileptic drugs, but 68%, that's more than 2/3, is spent on traditional medicine. So I will illustrate with African traditional medicine. In Nigeria, for instance, there's a strong preference for traditional herbal medicine. Epilepsy is really common, occurs everywhere, including rural areas, has been occurring for ages, centuries, hundreds of centuries, and millennia. So people already have some herbal remedies that they use, even though not effective and sometimes even damaging, as we will see. So 3.9% were receiving conventional anti-epileptic drug therapy. That's in a study in Igbora several decades ago. But the situation hasn't changed that much. Some of the herbal remedies include tetrapura, tetrapetra, leaves of nicotiana, um, some people use tobacco leaves. And of course, some of these things cause hypoglycemia and cause cerebral damage. The other one is the tau urine concoction. That was really surprising. It has several herbs in it, onion bulbs, fresh tobacco leaves, diluted with corn steep liquor. And people who took this developed brain damage as well because of the alkaloid that is contained in the concept liquid. Another thing is the issue of witchcraft being taught as the and possession by evil spirits, and this has led to magical ritual therapies, ritual dance, incantations, exorcism, faith healing. This is really very rife. And when people are undergoing this, they usually stop their anti-epileptic medications. And then because of that, they come back to the hospital with status epilepticus. So services in Africa in different places. These are some places where services are available, but they're really very few for treating, few and far between. What are the challenges? There's a wide treatment gaps results from a combination of low capacity in healthcare systems, inequitable distribution of resources, and low prioritization. And of course, factors that widen the gap are staff shortages, as Professor Walker Humbag mentioned. One doctor to population ratio in Africa is about 1 to 3,000 or 1 to 4,000, not to talk of neurologists. Sub-Saharan countries in Africa without even a single neurologist. Limited access to anti-seizure medicines, even though they're essential medicines, but 75% don't have access to them. Lack of knowledge and confidence of primary healthcare workers in the management of epilepsy, meaning a lot of training needs to happen for them to task shift. They need to know when to refer. A lot of misconceptions. Is an age-old, century-old, millennia-old disease, and a lot of stigmatization. Those are things we need to deal with. So the gap, some of it are from individual factors, some are community-based factors, some are health service-related factors, and some are a combination of all of those, like long distance to facilities, traditional beliefs, unavailable essential medicine or artificial medications, poor patient handling, poor documentation, poor knowledge of causes, lack of diagnostic equipment like MRI or CT scan, if it is due to stroke or cancer or brain cancer, or meningitis, proper diagnosis, or encephalitis, poor health-seeking behavior, or going to non-orthodox places, alcohol consumption, and so on and so forth. These are the things we need to deal with. And what are the effects of these gaps? Of course, a lot of complications, impairment of physiological function, accidental harm, self-harm, isolation, psychological is the same. I mean, a lot of disabilities in all the different dimensions, cognitive dysfunction, social dysfunction, lack of participation, low level of education, unemployment, and so on and so forth. And all of these, like I told the story of the general that nobody knows is even has seizures, and he's able to get rapidly promoted and fulfill his life mission, ambition without any hindrance or let. So you can see the complications. Uh, when patients are having seizures, they put their feet or hands in fire, and that causes a lot of damage. Pour hot water on them, make them drink concussions, and then a lot of stigmatization and discrimination, including laws. In some places, there are not even laws that regulate driving, which is important because until seizure is controlled more than 2 years, you really don't expect people to who have seizures to drive because if they should have a seizure attack while driving, of course, that could be fatal not only for that person but also for the passengers and other people using the road, including pedestrians. So stigma is everywhere. workplaces, health facilities, government schools, family, community, and so on and so forth. Internalized stigma, the level of the person, interpersonal, and the family level, whereby, in fact, in some places, people don't even marry from families that have seizures, some people think it's infectious or contagious, whereas it is not. And then institutional stigma. Uh, People get discriminated against at work, and they don't have laws to protect them. So, a lot of initiatives by the WHO and by ILAE and IBE to try to, deal with the treatment gap. Up until, I won't go through the whole thing. I mean, that started all the way from 1997 up to 2020, let's say 2018, when certain countries demonstrated how these gaps can be dealt with, including countries in Africa, Ghana, Mozambique, and of course, Myanmar, Vietnam. So the ILAE, the IBE, and WHO then came together uh, at the World Health Assembly, in 2020, to call for a development of intersectoral global action plan for epilepsy and other neurological disorders. And this saw the light of the day. I won't go through all the memory lane. The targets, of course, were 90% of people with epilepsy should be diagnosed, 80% should have access to treatment, 70% of people should be controlled. That is the 90-80-70 cascade of GAG. So this saw the light of the day, and the Intersectoral Global Action Plan was eventually launched in May 2022, as we are mostly aware, uh, and now including other neurological conditions, but using epilepsy as a gateway, putting brain health at the center, and reducing stigma, and people-centered primary health care and universal health coverage, which are really very important, and empowering people with neurological disorders. So prioritization, diagnosis, treatment, promotion, prevention, research, innovation, public health approach. These are all the things, of course, also with global targets, which are also listed here. So integrated care, universal health care, primary health care, social system, integrate into mental health care, NCDs, communicable diseases, social determinants of disease. Epilepsy care also overlaps with other neurological conditions, some of which are even causes of epilepsy, uh, dementia, stroke, traumatic injury, neurodevelopmental issues, headache disorders, and so on and so forth, and across the entire continuum. But what we are focusing on today is rehabilitation. And Volker generously showed some of the presentations of some of the pictures and figures from this publication on the need for global synergistic actions to improve brain health for human development, putting brain health at the center, and looking at spiritual well-being and physical, mental, which are all related. So access to services for epilepsy is possible for 70% of people with epilepsy to be seizure-free. And the treatment gap is 75% in LMIs, particularly in rural areas. So it's important to engage and support people with epilepsy. Families are often stigmatized. And then human rights violations, social exclusion. These are some of the things we need to deal with. Children with epilepsy may not be allowed to attend schools. Adults may not find suitable employment. So all of these needs to be dealt with. So it's an entry point for dealing with other neurological conditions, because some of these conditions are also causes. Traumatic brain injury, stroke, for instance, causes. So there is implementation toolkit for the WHO Intersectoral Global Action Plan, which is freely and widely available. And that includes doing a situational analysis and then stakeholder engagement, prioritization, diagnosis, promotion of brain health, research innovation, and approach to specific neurological conditions. So all of these are important, so that by 2021, countries will have increased service coverage for epilepsy for 50% from the current coverage in 2021. So that is the target. And 80% of countries will have developed and updated legislation that will protect people living with epilepsy. So the position statement was given and was ratified and supported by most countries. So start talking epilepsy and then of course the strategies. So what's next? 100% of countries should be committed to the high gap, and that has been achieved. But we also want 100% to have data on epilepsy services. That's yet to be achieved. We want 100% of national health plans budget to feature budget for epilepsy services. We want 90% of people with epilepsy to be aware of their diagnosis, that is to be diagnosed and to be commenced. We want 80% of them to have access to treatment, 70% of them to be controlled by 2031. So those are the targets. Is this feasible? Of course it is. And those targets are achievable by 2031. But it's important to make communities epilepsy literate, to enable primary care providers to diagnose and treat at least uncomplicated seizures, and to integrate innovative technology in primary healthcare uh, uh, to drive epilepsy management, including telemedicine and telecare and telerehabilitation. And so detection is important, awareness, evaluation, diagnosis, and initiation of medication. So individual factors, disease factors, system factors needs to be. So a practical approach, of course, is like we've mentioned, phenotyping or characterizing that epilepsy. And then, of course, beginning treatment once that is sorted. This is an algorithm that can help to know whether it is seizure or is not seizure. And if it is seizure and the second seizure is occurring, then it's epilepsy and treatment is required. So, and this is what can be implemented at the primary healthcare setting. Evaluation in the emergency room. If seizure is not confirmed, nothing is needed. But if seizure is confirmed and second seizure occurs, refer to a neurologist, or at least have some supervision from a neurologist to ensure partnership and adequate evaluation, proper characterization, diagnosis, and treatment. Mostly medications. In some instances, epilepsy surgery may be required, and treatment of the underlying cause of the seizure or the epilepsy may also be needed. But more importantly is reassurance and education of the patient and the family about what needs to be done. So AEDs are potent, but they must be selected. There are the old ones like carbamazepine, phenytoin, primidone, lamotrigine. We should be conversant with their side effects and their mechanism of action, and complementary effects when you can't achieve seizure control with monotherapy, which is really what we want. But if monotherapy is not working, then rational polypharmacy can be required. And then newer AEDs tend to have less side effects and including less drowsiness and less cognitive side effects. But aim, of course, is still to achieve seizure control. EEGs are useful, but they usually inter-ictal, and so because they are inter-ictal, sometimes they may be normal in someone who have seizures. And so follow-up is also important on the seizure control. Titration of the medication on the seizure control is achieved. And if it is refractory seizure, then we need to find out if there are underlying brain pathology that is responsible, which needs to be dealt with, or medications will need to be adjusted until seizure control is achieved. If patients remain seizure-free for 10 years and off anti-seizure medicine for at least 5 years, then we will say resolved. But we don't use the word cure. So solving this, we need to work with everybody, all stakeholders, including NGOs, including the private sector, including policymakers, including lawmakers, to ensure that patients are adequately evaluated, treated, and that stigma is dealt with. So driving should be possible once seizure is controlled. Employment should be possible. And epilepsy in some countries is classified as a mental disorder. And that leads to diminished legal capacity, challenges with getting married, and so on and so forth. So these are things that need to be dealt with. So care pathways must be identified, and perhaps we need to partner with the non-orthodox practitioners, faith healers, traditional healers, and so on, to ensure that when patients come to them, they actually refer them to where they can get adequately evaluated and treated. So we need to raise policy prioritization for epilepsy, provide effective, timely, responsive diagnosis and treatment, implement strategies to promote health and, of course, prevent seizures, foster research and innovation for new ways of treating epilepsy or even curing it in the future. That may be possible in the future to actually even cure epilepsy. In fact, some can be self-limiting. Some of the genetic syndromes are self-limiting. Some you can deal with using lesionectomy with focal seizures, but 70-something% can be controlled using medications. So thank you so very much for this opportunity. The Lancet Commission on Neurorehabilitation, we're also including epilepsy as one of the key features that needs to be included in the Lancet Commission. Thank you so very much for this opportunity.
Thank you very much, Dr. Mayawasa, for highlighting the gaps in the treatment of epilepsy, and that's further widened by the stigma, especially in the developing countries, and the ways that we can bridge this gap as well. Thank you so much for the wonderful talk, sir. Next, we have the bridge between the epilepsy and rehabilitation in the road to recovery, the role of the multidisciplinary team, the story of the Epilepsy Foundation, and that's by the master himself, Dr. Nirmal Surya, sir, my mentor. Over to you, sir.
Thank you, Guhan. If I'm able to share my slide, please. Yeah. Are you able to?
Yes, sir.
Visible? Okay. Thank you very much. It's a great opportunity. I want to wish and thank everybody for on the occasion of National Epilepsy Day. So why neuro rehab in epilepsy? That's a question comes. And when we talk about this, we know that epilepsy can affect motor system, it can affect language and speech, learning skill, behavior, memory and cognition, swallowing. It affects social function like education, marriage, job. It's a family burden and psychosocial comorbidity. So it's a neurological condition which is associated with cognitive, psychosociological, and social consequences. Cognitive problem in patient with epilepsy can be caused by lesion that causes the epilepsy, frequent or prolonged seizure itself, or some extent by even anti-epileptic drug. And most common are memory deficit, impaired attention, difficulty to concentrate, and fatigue that may impact the daily life. So prevalence of memory disturbance in people with epilepsy may vary from 20 to 50%, and this can be debilitating sometime than acute seizure. So why need to worry? Medicine alone may reduce the epilepsy, but yet person is not productive. So time has come to deal the disease epilepsy in total like any other neurological disorder such as stroke, Parkinson's disease, or Alzheimer. And like any other neurological disorder, we need MDT to join hand with the patient. So why I call epilepsy as a hidden devil? Because it affects all ages. For child, the parents are affected. The adolescent growing up with epilepsy, they have different problem. Adults with epilepsy have more trouble. Elderly people are different issue, alone, dependent, spouse, nobody bother, caregiver, they are hidden. Mother with epilepsy, late onset but versus early onset, chronic cases. So illiterate rural travelers overtly God-fearing and blaming epilepsy as a curse. They accept the disease, do nothing. Literate urban dwellers, but not so different needs, stigma and poor attitude, run from pillar to post with no solution. Taboos and catastrophe of patient who are seizure-free post-op find difficulty to accept normalcy, family expectation, and new life is suddenly they are exposed and they have to look at between past and present. So these are some of the issue. So here you have an epilepsy with maybe with neurodisability or without neurodisability. So those with neurodisability can have physical, speech and swallowing, learning, cognitive, psychosocial, and then among the cognitive is memory, behavior, ADHD, autism. Now, factors that affect cognition in epilepsy are well known. It may be largely may be irreversible because of either the encephalitis, tumor, etc. And there may be clinical and demographic feature like age at onset, topography and localization of epilepsy. And then there are functional factors which can also be responsible. There is a correlation between IQ and seizure frequency. And if you look, IQ score, repeated seizures are associated with increased intellectual impairment. There is a clearly link between epilepsy and language, and neuropsychological impairment, including cognition and language, is a significant comorbidity of epilepsy, affecting about 82% of children with epilepsy. So that's very, very important. And fMRI in children with epilepsy shows atypical hemispheric language dominance, either predominantly in right hemisphere or abnormal bilaterally. In visual interpersonal social functioning in epilepsy can be looked into this affective process and cognitive process. Then you have on one side, patient with society and culture environment, family peer group, partners and family. And on the other side, you have the structural lesion, functional lesion, epilepsy activity, AED, psychiatric comorbidity, and development trajectory. So particularly in children, they are challenging. 20 to 30% of patients with epilepsy have a psychiatric disturbance, and 70% may have one or more diagnoses consistent with DSM-3R, and 58% of this have a history of depressive episode, and risk of psychosis in patients with epilepsy may be 6 to 12 times that of general population. These are some of the psychiatric conditions which are associated with epilepsy, and you could see that there's a great difference between control and patient with epilepsy. Either it is major depressive disorder, anxiety, mood, suicidal ideation, or other. The rehabilitation of neurodisability in epilepsy, that is very important, and continuum that start at point of identifying need. It may begin acutely after the identified injury, or may not be initiated until problems are identified. The goals of phase of rehabilitation are to focus on increasing strength, stamina, coordination to facilitate mobility, independence in self-care, and address the issue of cognition. Phases of rehabilitation may be quite extended with flexibility required to adapt changes that occur over time. And you have multidisciplinary team which is around the patient to take care of the patient. We in Maharashtra has developed this model of Maharashtra care of epilepsy care with National Health Mission, Government of Maharashtra, funded by the Government of India, where we have developed in PPP from 2011, a kind of a model which is unique to take care of the patient with epilepsy, not only for their care, but also for the rehabilitation. And we, in 106 camps over a 13 years of period, has seen more than 35,500 patients, where the EEGs are done for nearly 44,750. But important thing is there's a counseling, physiotherapy, occupational therapy, speech therapy, which is done for the nearly 8 to 10% of the patient who are visiting the rural epilepsy program. So these are the performa which are individually being filled up. So this is for the physiotherapy, and then the physiotherapy we have as many as 15% of seizure are reported in the emergency department, and there may be injuries associated with the epilepsy like fractures, dislocations, and children with cerebral palsy have a higher prevalence of epilepsy as compared to the other. And in our data where we have evaluated in certain camps about the epilepsy and physical comorbidity, the motor milestones are delayed in out of 159 patients in 103, and there are contraction and deformity present in nearly 59 out of 159 patients. And ADL, if you look, that they are dependent in 63 patients, while muscle power was poor in 35 patients out of 159. And we also did a group exercise program in the rural, because we will not be able to give them time and do one-on-one. And we did an observation over a 2-month period where MMSC score was above 18, and we taken 10 to 20. And the mainstay was the common comorbidity with patients living together, particularly those who are in the special school or shelter. And we taught one of the teachers the Arabic exercises, And we really, out of 857 patients, 110 patients required physiotherapy. And patients participated in these group exercises, underwent this program, and we gave them how do they do it regularly. So this is something a leader among the children has been uh, uh, identified, and they were taught to do it regularly. So group therapy is a useful thing which we found out in the camps. Then this is a performer for OTs, and from the OT perspective, children with epilepsy present with multiple comorbidity in motor, cognitive, and behavior, heavy burden on children themselves, their family, also on healthcare system, and there are associated comorbidity which needs rehab program in these children. So we have evaluation, caregivers interview, individual intervention and training, group intervention and training, and community health worker intervention, all being done in the camps during this, and then followed by the tele-neuro rehab after the 1 month or 2 months to have their follow-up. So if we have evaluated 2,279 patients who have various kind of learning disability, ADHD, learning disability and behavioral issues were most common, ADHD, autism, ID and GDD, like cerebral palsy, are also being seen. And if you look at the component in impairment, psychosocial is 33%, cognitive 22%, and sensory-motor was 45%. And ICF activity participation limit, if you see, they could play 23% patient, but ADL was only in 61%, and work school was affected with 15.4%. Prior exposure to OT services, never in 53% of children, once in 20%, few times in 16, and discontinued in 10. So you can see that there's a great need of OT. And reason for not seeking OT services, they have no time, unaware, no use, given up. So, really we need to work hard on that. And if we look at further what we provided intervention, neurodevelopment, sensory integration, biomechanical, psychosocial, and rehabilitation. And this restorative approach which we use, and in severely profound children, a maintenance approach was used. So depending on each, and these are the role of caregiver and community health worker which was trained, and their role of feasibility and sustainability of OT services was explained to them at civil hospital. And their satisfaction, if you look at that, the community health worker were mostly satisfied after the camp, and most of the people, community health worker took over from that. I'm not going to go in detail on this camp video. This is quite a big, and these are the speech therapy perspective. This is the performer which has been filled, and our Pune team has really evaluated nearly 3,160 patients in the various camps, and that they saw about 441 patients, 253 till 27, and thereafter based on referral to the team appeal. And these are the speech therapists who work, and they give the program to the children. There are 4 or 5 present sometime. So 441 children, out of which children were 295, adolescent 89, and epileptic SLD was 298, non-epileptic was 143. And these are the clinical observation which was seen by these SLPs in the camps and evaluated them. Again, they gave the exploration of the speech therapy as a group therapy. They taught them what are the various exercises, how they can do it, and that has worked. So these are some of the things which we have tried. Similarly, this is the assessment by the counselor who has seen the people who are referred to them, nearly out of 23, 778 patients were evaluated, and they have psychiatric comorbidity, depression 67%, anxiety 29%, psychosis 11%, intellectual disability 29%, suicidal ideation 35%, and pseudo seizure in 8% of patients. There's also substance abuse, and commonest is smoking and tobacco, followed by the alcohol. And if you look at the treatment status which they evaluated, poor compliance in 32%, on no anti-epileptic is 26%, and on an anti-epileptic is only 42%. And between the control and uncontrolled, those who have uncontrolled epilepsy, they have more psychiatric problem as compared to those who have uncontrolled epilepsy. So psychiatric comorbidity adult were underestimated, leading to poor quality of life and increase in seizure, 91% psychiatric comorbidity from mild to severe, and it affects the significant impact on quality of life, and they need to be treated properly. We also did COLI-10 analysis of nearly 238 patients over a 3 months period. And after the intervention, we found that this is how the 6-month follow-up we could see. And between uncontrolled and control, those who are controlled, they have a better COLI-10. And on therapy, you can see that baseline was high, and then over a period of time with therapy, the quality of life has improved, and which maintained over a period of 6 months. So intervention is something which helped with the team approach in this patient, and we have published this paper in one of the journal. We also encourage patients to actively participate and train them. We organize personality classes. We give them various kind of activities, employ them, give them play around, make rangolis, make certain bags, rakis, so they are involved. And we have, after the COVID time, we have published quite a few papers, and this was one of the yoga and epilepsy, which was quite useful. And these are some of the surveys which we conducted and presented at various conferences. We also wrote about the comprehensive epilepsy care during the lockdown due to the COVID-19 pandemic. And this is the protocol which we developed, where patients were treated, those with during the COVID, for the rehabilitation, and those without the rehabilitation. Our cognitive therapists, the neuropsychologists, also had evaluated many of these patients, and the children through the Brain Next program has been evaluated. During the COVID time, online therapy was given to these children, and they shown a significant improvement. We have presented again cognitive therapy in the COVID-19 period, and person with yoga and epilepsy. So this is something which we have done. So we are able to do quite a few studies during the COVID time online, and the Brain Next tool has been shown to be effective for the cognitive function. And you could see that out of 146 patients, the training for 19 months has shown a significant improvement from baseline in 6 months period of time. And this is how the program has shaped. We also look at the outcome of education to the frontline ASHA workers. So we have done a lot of program for ASHA workers, who in turn are able to identify the epilepsy patient and early treatment. So to summarize, our experience suggests neurodisability is a hidden devil in people suffering with epilepsy. Need for all concerned dealing with epilepsy is to identify and intervene at early stage. Comprehensive care of epilepsy management is the need of hour to improve the quality of life of people with epilepsy. Regular counseling at periodic interval could give a window for early intervention. Need to understand that AED medicine or surgery alone may not give you 100% desired result. MDT need to work in tandem with each other. Education to patient, parent, society, and lawmaker is the key to success. We'll need to do more systematic data to strengthen our observation and experience. We can change life with little resources if we work with the multidisciplinary team. Thank you very much.
Thank you very much for the wonderful talk on the story of Epilepsy Foundation, sir. And it's truly an inspiration for every audience and attendee here as to the amount of work that has been done in uplifting the people with epilepsy. And it not only has shown the patients the treatment of epilepsy and the need of rehabilitation, it has also emphasized for every neurologist across the country that rehabilitation is very important for the upliftment of life of epilepsy patients. And for the attendees, under Sir's leadership, Epilepsy Foundation has conducted over 106 free epilepsy camps across the state of Maharashtra, and that includes a multidisciplinary team in every single camp that has been conducted. Thank you very much, sir, for sharing your experience with us. Next in line, emphasizing the importance of rehabilitation in epilepsy, where the current world is moving towards epilepsy surgery. Epilepsy rehabilitation post-surgery. What should I do to maximize neurological recovery? The thought that rings in the mind of every neurologist. And we will hear it from the expert, Dr. Sangeeta Rawat, ma'am. Over to you, ma'am. Ma'am, your mic is muted, ma'am.
Thank you, Gohan, and thank you for little preponing myself. So, I- are my slides visible?
Yes, ma'am.
I'll just do the full screen. Yeah. So, I think Nirmal has said a lot of things about neurorehabilitation, how it is important for the patients of epilepsy. And I entirely agree that epilepsy has become a chronic disorder like Alzheimer or this thing. So, multidisciplinary to approach is very, very important rather than just treating the seizures and keeping them under control. And we experience this after the post surgery and during surgery. So we have almost 10 to 12 million people living with epilepsy in India itself, and surgery is indicated in almost 30 to 40% of patients of this refractory epilepsy. And also initially we used to do only anterior temporal lobectomy, but now we are doing more and more complex surgeries with stereo EEG and others, and with a maximum now we are focusing on the disconnection of epileptic neural pathways. So that is the important change which we have developed now. So what are the risks and why should we undergo surgery? So benefit is that with an expert team, a detailed pre-surgical workup is done well. The neuropsychological evaluation is the surgery can be as important to have a curative surgery. And in some cases, we already know it's a palliative, but the cure is possible. And if it is done early in the children, it can prevent the detrimental cognitive, behavioral, and psychosocial impact. So he can start schooling with normal thing. And also the overprotection by the parents can be prevented during the, their learning years, and their major development is happening during the school. So earlier the surgery, the better outcome it is. I think in all pediatric papers, it's very well demonstrated. Yes, see, anyone a hernia can have a problem. Hernia surgery can also have a problem. Similarly, anyone driving on the road can have an accident anytime. So there are some risks associated with surgical this thing. So it could be a hemorrhage, infection, maybe a minor stroke. It could be anesthesia complication or a delayed wound healing. Apart from that, you can have a cognitive difficulties, visual field impairment, mood problems, a new psychiatric complication occurring. And depending on the type of surgery, whether we are taking a corpus callosotomy or whether we are doing a spherectomy, you may have a hemiparesis, which is an known, it has been already told to the patient that you may have this deficit. And after that, the patient has decided to go for surgery. So why is neuro rehab required? So as you said, neuro rehab is, it aims to restore, minimize or compensate to the greatest possible extent for functional deficits. So you may have with disability, but also you may have other deficits, like you may have a important thing is that you have to have a mental and social potential also bringing back to the normal level. So you have to, important key points are educational. They should go further in their studies. They should be actively involved in the world. And those rehab should be patient-centered. So you cannot have a same protocol for everyone. You have to have a patient-centric, personalized protocol, and facilitate the self-management, how they can do on their own, how much they can do. And periodically, we have to review what the rehab is bringing out. So the challenges are that some of them definitely do develop when you have a resective surgery in parietal lobe or a frontal lobe. They may have a neurodeficit, but in these patients are often if you're done in a younger children, the neuroplasticity is good, and they often have a transient deficits, and majority of them recover well. I will be showing one or two cases of that. Cognitive, mainly memory issues in temporal lobe epilepsy, speech and language areas if it is on a dominant side. Psychosocial, some may have a mood, behavioral issues, also often burden of normalcy. I'll talk about it later. And challenges for the reintegration. So, moving forward in the life and status shift, that they started studying, they got a degree, they had marriage, they had employment. All this is also important for a complete rehabilitation. So when we already said, everybody said it's a disorder, it's a spectrum disorder which has neurological, cognitive, psychosocial and social consequences of this. So hence successful surgery is not just a seizure freedom, but you must have a cognitive, psychiatric, quality of life, psychosocial outcome. All this should also improve. And even for the after complete seizure freedom, many patients continue to have the social stigma. They don't get employment, and they don't say that they are 100% happy with this. Sometimes, despite seizure freedom, patients are a bit confused about when they can drive and whether they should be out of the overprotection, whether they are acceptable, which activities they can do, whether they can do swimming, whether they can do what further thing. So those, if you have a guidelines and if you tell them systematically, it is more important. And when sometimes how much rest you require, how much when you can start working, they do appear confused if it is not well told to them and not pre-op rehabilitation is not done well. Also, we've seen that sometimes the patient right temporal lobectomy, after that, we have seen the new psychiatric problems may start, and anxiety, irritability, and sometimes I've also seen a schizophrenia coming up after this thing, and where it was a minor trait, but post surgery, it has become more problematic. So the holistic approach, being a psychiatrist also in a team and a psychologist also in a team, is very important. So you know, epilepsy is a chronic disorder. So years together, they are in this, being a sick role, and they get all the favors and they get all the attention in the house. And now suddenly it is a reverse transition. So the patients experience that from chronic disability, they go to sudden wellness and giving right. And then they have a different rehab need. So that's why that multidisciplinary team is important to give physical, cognitive, and psychological, rehab compared to apart from the seizure freedom. So what do you know for the physical rehab? So, this apart from the disability which you have, it's simple things like a post-temporal lobectomy. They often tend to have, a mouth opening is restricted. So we have to say that they have to start doing those exercises. They have to have a regular chewing gum eating or, exercise for chewing. And these are simple things. If advised post-surgery, it will really help in preventing the contractures which often they develop due to the pain here in the temporomandibular joint. Another important thing is cognitive rehabilitation. This focuses mainly if you have identified in pre-surgical evaluation that patient has memory is already gone down, there is no problem. The patients post-surgery will do well because they are already at the level where they are using either strategies or whether they are doing something else. But if the memory is preserved and you're going to remove that temporal lobe, then you have to have you have to teach the patients how to deal with it. You have to prepare the patient before it. Emotional and psychological, this is often required because the patient, the overprotection, the center of attraction, and all the extra care which they eventually go away because everybody thinks now you don't have an epilepsy, so you are a normal person. But the problem is that so many years he has been not a normal person. He has not learned the things which are supposed to be taught during the schooling, and also he cannot suddenly become a normal person. And that is important to tell the family that how to go about it. Also, like the simple thing, like I had a patient who was undergoing a right temporal lobectomy, and the father was a tailor, and he thought that after the surgery, seizures are well controlled, he'll go to become a tailor. But we had to say that he cannot become a tailor when we are going to remove the right temporal lobe. So then we advised him that then he said, okay, I will open a restaurant for him, a small restaurant, and then he did well after that. So such what employment they will take and how the which further how he can study, and realistic expectation post surgery is very important. So for the physical rehab, I think I won't go into detail, but some of this is roots approach where sensory stimulation is there. I think Dr. Surya has already told this. Proprioceptive neuromuscular rehabilitation, and encouraging the movement, especially in cases of hemiplegia, by Burn-Tom approach, mirror therapy, mental imagery can be used to in addition for the motion exercises and chest physiotherapy, and very important relaxation techniques, conscious effort to get relaxed, to relieve excess tension in the muscles. So for cognition, the word used is a prehabilitation. It's very effective. So you tell the patients before and the relative that a psychoeducation program and how full modeling before the surgery, they have been taught that what is going to happen post surgery, how they are supposed to deal with it. And they are also taught the strategies that you can keep a diary or what you can do it. And if there are a memory impairment are going to be there. So it aims to change the, changes that which they may experience. They are prepared for those situations. And then the same, once you prepare them post-op, they are quite anticipatory to this, I have to deal with this, and that improves their, approach to the post-op rehab much more. So for the memory rehabilitation, we are mainly four categories. One is a restorative, that is retraining of memory, that is using memory games, activities, and it is based on the principle that repeated practice may stimulate the existing neurons to form new connections. Second is specific knowledge acquisition, learning information relevant to the needs in daily life using like mnemonics, environmental modification. You may have some signs or tables which are put up for him to remember. So this also helps in specific knowledge acquisition. And compensatory, so you may use a diary, you may use a calendar, you may use in the smart technology on the phone or a tab, you have the reminders set up. And this will definitely, though it's an external thing, but patients can come over their deficit of memory with this external help. And it's also a holistic approach addressing the emotional and social factors along with the cognitive consequences. So the burden of normalcy, which I said, as they are already suddenly they become a normal, and they have been taught that you have to go to the market and do this shopping, you have to do this cooking, and you have to start doing this to get good marks. But it is important that their IQ is not changed post surgery, and their memory also might impair if there is a temporal lobectomy. And they have lost important learning years over in the schooling, and also they cannot suddenly go to normalcy. And this is important to tell the relatives, colleagues, and the peers to, and otherwise so often everybody expects, their expectation from the patient becomes so high that he gets depressed, that I cannot cope up to their expectations, and that leads to further anxiety and depression. So it is important that we tell the patients and the whole family what are the realistic expectation, what will happen post surgery, what is going to change and what is not going to change. There was a comprehensive model for neuro rehab post epilepsy surgery, which is also called as this ERAS. So it is there for the other surgeries, but now I think enhanced post surgical recovery and rehabilitation. But now it is important that we start this also for the epilepsy. So the pre-surgical evaluation, important comprehensive neuropsychological and psychiatric assessment is very important. Neurosurgical consultation and preparing them for the prior 2 to 5% chances of deficits. Also telling them that what are the factors in pre-rehabilitation regarding what could be the expected outcomes. And also identification of patient at risk and prepare them, and take an informed consent that these are going to be the deficits, and after that, if they're ready, then go ahead with surgery. So once the surgery is done, immediately post-surgery in first 3 months, I think active physiotherapy, occupational therapy, and psychological and psychiatric review should be done regularly, especially when they already have a pre-surgery psychiatric problem. Then it is important that he continuously follow up with psychiatrist along with the neurologist also. And then at 3 to 12 months, of neuropsychological rehabilitation, vocational training, if required, for the, as I said, I gave an example like that, and other psychological and social support from the family, from the teacher, from the employer, all can be, told them to have it. And then later on, also comprehensive review should be done. And then we should have to have a goal. Okay, you are supposed to now, after this many months, your career should start, and you should plan this. Also, career counseling can also be done. If we have done the surgery, we know what things he will be able to, or patient will be able to do. So it is often important the psychologist also counsels them for the career, what they can go further. So this comprehensive model is very important to follow post surgery, and this will make the patient not only seizure freedom, but he'll be a happy person, that his status shift occurs. He starts studying, gets married, has employment, and does better in life. So just to give you example of one or two cases, this 8-year-old girl had a FCD in a high parietal central sulcus, and they were very high frequency, almost 7 to 8 episodes per day, close to motor strip. So the first surgery we did ECG guided with intra-op neuro monitoring, and we were just stopped close to this thing so that she doesn't get a deficit. So we stopped just next to the motor strip. We stopped. She had some time for seizure freedom, but again she started having surgery seizures. So she was reoperated in 2021 after counseling that there will be a hemiplegia, and then we also did the calostomy. And as she was pretty young that time, 9 to 10 years, she had a hemiparesis, but family was well counseled and told about the intense neuro rehab, and the younger age led to a better improvement. Now in 2024, she has no issues, no seizures. She's studying in 10th standard, and they are very happy family, and she is independent in daily functioning also. A second case, a 14-year-old girl, again had a very high 18 to 20 seizures per day. And she also had a left inferior parietal lobe FCD. And there was an intermediate risk for motor deficit, as the functional MRI showed the supplementary motor reactivation was there in the hemiplegic person. So we counseled them. She had a hemiparesis post-op, but we did the intense rehab, OT, PT, speech, everything. So in 2023, when she followed up, there was a recovering language issue, almost 90% improvement in lower limb, mild hand grip weakness was there. But family is very happy, and the patient is also happy. And when I called them up, they sent this video showing that though she had a mild deficit in the leg is still there, but she's doing much better. And the seizures have stopped in spite of this mild deficit there. And when the patient are counseled well, they accept the risk and the deficit much better. So there's a last case, a 33-year-old gentleman who came AutoCAD engineer, and he had a good intact memory. So we told him not to undergo a left temporal lobectomy. But since he had a weekly CPS, he couldn't go further in career, he couldn't get married, he had a mood and behavior issues due to epilepsy. So informed choice was made, and he underwent in left atrial in 2013. So he did have a hit in his memory, and he was advised comprehensive cognitive rehab, and he learned the compensatory strategies. And then over the years, he had a good outcome with good cognition because he was an intelligent person, so he could overcome. And in the last follow-up, he was seizure-free, drug-free, he's working in Saudi, married, and has a kid also. So if there is a deficit, and if you have told them that how to deal with it, the patients can do much better. So it is pre-rehabilitation, so pre-op counseling, to see how much of the intactness or how much it is down, and then post-op handling together makes a lot of difference. So the takeaway message is that rehabilitation should be an integral part of epilepsy surgery program, just as we have a video EEG and MRI, and pre-rehabilitation and continuing rehabilitation is crucial to have a holistic benefit of epilepsy surgery along with seizure freedom. And enhanced recovery after surgery. ERA's protocol for epilepsy surgery must be followed in all the things. And the team approach for multidisciplinary with OTPT, speech, neuropsychologist, a surgeon, and a psychiatrist is important for the whole thing. Thank you very much.
Thank you very much for the wonderful expertise portraying the importance of prehabilitation and the post-surgical rehabilitation, ma'am. It was a wonderful learning experience for all of us, ma'am.
Thank you.
Next, we have epilepsy rehabilitation in special population, from pediatrics to geriatrics, and to listen to it from our expert, Dr. R.K. Damija, sir. Over to you, sir.
Thank you, Gohan, and thank you, Dr. Nirmal Surya and the team for organizing this important webinar on National Epilepsy Day. So my greetings to all of you on the International Epilepsy Day, and a host of programs are being organized today, and I'm glad that we are part of it. So coming to the topic assigned to me, I will not be using slides because I see the audience mainly the general population as well as the general physicians. So I will just give some hints about the how to rehabilitate the epileptic patients in these three special populations, which is pediatrics, geriatrics, and of course the women living with epilepsy. So these are three main special groups which I will be talking about in next 10 to 15 minutes, and we will give you the certainly the important aspects of how to manage, how to rehabilitate these patients. As per the WHO, there are 50 million people living with epilepsy. So about 5 crores. This is underestimation. And thank you, Dr. Sangeeta, for quoting our paper on burden of epilepsy in India. About 10 to 12 million people in India. That means more than 1 crore. But actually speaking, there are much more epilepsy because of the stigma, because of the underreporting, and alternative treatment options available and being used by many of these epileptics. So I believe that numbers are much more in India as well as in other developing countries. And WHO says that 70 to 80% of epilepsy burden is in global south. That means the lower and middle income countries where the resources are poor, there is a stigma, there is a poor health literacy, and there are options of alternative medications available and being used by the patient. So that is very, very important. So let's talk about epilepsy in general. So each epileptic patient is quite different in terms of their treatment response, in terms of their toxic effects, and in terms of their disease profile. So while we discuss the treatment of epilepsy in targeted population, I think these particular targeted population or vulnerable population, children, elderly, and women are considered to be special because of their metabolic and physical differences that require particular care during the treatment of the disease. The treatment options also vary significantly among this population. If we talk about metabolic differences in very young and elderly patients, they require very close attention by the prescribing physicians in terms of the rate of metabolism. For example, in children, the rate of metabolism may be much faster than the non-elderly adults, that means the normal adults, requiring dosing adjustment to ensure enough medication used to control seizures. Additional concerns with treating children particularly include their increased sensitivity to toxic effects, because they tend to have much more modulation, and titration is required. And sometimes we have a different etiologies also for epilepsy in children, whether it is the birth asphyxia, or it is a neurodevelopmental disorders, or it is a neuroinfections. So all these etiologies are quite different from the epilepsy in adults, and we have to be mindful of those while managing these patients, managing the children. Sometimes you require extensive neuroimaging, electrophysiology, which may not be very much in demand for required in the adult population. So children have a very specific group in terms of their rehabilitation. We will discuss in detail about the rehabilitation aspect of the epilepsy in children. While coming to elderly, I think they also have very different metabolic rates. Their metabolic rates could be very slow because of decreased renal or hepatic function, and thus these patients can easily be overdosed while the normal drugs levels are maintained. So their clearance is reduced. So obviously they will have a much more toxic effects, but their duration of treatment is much risk of adverse event, and every fall in elderly can have a very, very heavy consequences. So obviously the treatment duration has to be longer than the children or the adult population. Many of the juvenile and many of the children population in adolescent may have a juvenile myoclonic epilepsy, which requires sometimes lifelong treatment or a longer duration treatment. So that is the difference from the normal adult population, where we see the anti-epileptics, anti-seizure medication given for a few years and then can be titrated if the symptom-free or seizure-free is maintained for 3-4 years. Obviously, you can titrate and see if the patient can be taken off the medications. Other aspect of elderly population is they may also have a concomitant illness, that means comorbid conditions, and drug interactions are very, very high for these patients. Obviously, the potential of drug interaction has to be taken care of and has to be considered by the prescribing physician. The drug cocktail or the polypharmacy in elderly can be very dangerous. So while maintaining adequate seizure control, one has to be cognizant of that the polypharmacy is avoided, considering the other diseases, considering the fact that these patients can also have a metabolic derangement like hypocalcemia, hyponatremia, hypoglycemia. All these features, all these conditions can also lead to the seizures. And of course, one has to be mindful that every seizure is not an epilepsy, but certainly the elderly population requires much more titration, much more monitoring, and much more in terms of their overall rehabilitation. Now, coming to the women are considered as a special population because of the issues related to their contraception, childbirth, and breastfeeding. And some of the anti-seizure medications are known to reduce the efficacy of the oral contraceptives. So obviously, one has to be very, very careful when we are combining the oral contraceptives on one hand and anti-seizure medications on the other hand. So that is something which we have to keep in mind, increasing the contraceptive doses or anticipating contraception failures in women taking an anti-seizure medication and contraceptives, oral contraceptives. So one is very, very important. And coming to the pregnancy, preconception counseling is very, very important and has to be offered to all young women who are planning pregnancies if they have a seizure or if they have epilepsy. So obviously, the preconception with folic acid treatment and other aspects of epilepsy management has to be very, very clearly explained to the women about the continuation of anti-seizure medication, which is equally important. Many of the girls or many of the women think that now in pregnancy, for the safety of the baby, the medication can be avoided, particularly in first semester. But no, never ever. The anti-seizure medications have to be given. Sometimes we may think of changing medication before the pregnancy or even in the first semester, but never ever stop in the anti-seizure medication during the pregnancy, because that is very, very important to control seizure. If the lady has a seizure, that can also be catastrophic, and we know the consequences of hemming every single seizure being catastrophic. So obviously, the women has to continue the anti-seizure medication, and many of the pregnancies can be carried on very normally. In fact, the neural tube defect in a normal pregnancy is reported to be 2%, while in pregnant women with anti-seizure medication, it is 4%. So obviously, the anti-seizure medication cannot be stopped. It can be changed, having a little more safer medication these days. And some of the medications are much more superior than the others in terms of their pregnancy effects. But having said that, if the seizures are controlled on an optimum doses, even in valproate less than 700 milligram, one can continue and one can have the levels, one can have the supplementation with the folic acid as well as with the calcium, vitamin D supplementation. So the pregnancy can be carried out normally. The third trimester is very important for rehabilitation in terms of the seizure control, that any seizure could be very, very, again, harmful for the baby as well as for the mother. So during delivery as well as during third trimester, extra care has to be taken, and a combined management approach by obstetricians and as well as neurologists is important. And during labor, sometimes we need the extra anti-seizure medication, particularly benzodiazepines, so that the delivery or the stages of labors can be carried on normal circumstances. So these are very, very important. And I think all three special populations need rehabilitation in terms of their aspects of psychosocial, their aspects of, having said that, the pre-seizure, post-epilepsy, post-surgical, post-seizure, these things are very, very important, and something which we always, it's not a disease, it's a disease, chronic condition affecting family, affecting children, affecting elderly. So everybody has to be involved in the management and rehabilitation, and particularly the special population, including children, elderly, one has to be very aggressive in education. The people with epilepsy and their families need ongoing education and skill building, especially during the transition period from children to adolescent. Nowadays, we have the adolescent clinics or transition clinics where pediatric neurologists are handing over the patients to the adult neurologists, and that period of 2 years from 16 to 18 years is very crucial in terms of the child sensitivity to the neurologist, treating neurologist to one hand, and the lots of changing happening across the physiological changes and across the world. You're exposed to certain information from every corner. So obviously that transition has to be smooth and very, very important for awareness and for carrying on the transition from a pediatric aspect or a pediatric department to the adult department. So one has to be very importantly educating the parents as well, and the acceptance has to be there for smooth transition from child adolescent to the adulthood. The other part of neuropsychological rehabilitation, that is again important for children. They can have a cognitive deficit, which are usually associated with epilepsy, and neurocognitive or neuropsychological rehabilitation with a team of psychologists or neuropsychologists is equally important, and that can improve the quality of life as well as the overall outcome in these patients. Dr. Sangeeta talked about prehabilitation. This is very important. Before epilepsy surgery, patient can use their intact cognitive functions to establish compensatory strategies and routines, which Dr. Sangeeta already mentioned. And prehabilitation is now becoming a norm in all epilepsy patients who are refractory to anti-seizure medications and are planned for surgery. The psychological resources can also be very helpful for these patients as well as for the caregivers. And last but not the least, the social and vocational rehabilitation are very important in terms of to address their psychological challenges, people living with epilepsy, elderly, the children, as well as the pregnant women. Very special population, their special care, special needs, and a combination approach from the obstetricians, from the pediatricians, with the aid of rehab physicians, rehab professionals, all the therapists, including speech therapists, the physiotherapists, the occupational therapists, they all have a role to play in these three populations. And I think many of the audience will have so many questions related to the last thing which I must mention about the breastfeeding. And of course, women have a special consideration, not only related to the childbirth, but also breastfeeding. And one has to be very clear about benzodiazepines, particularly long-acting, which may be created in the breast milk. And obviously, one has to change the strategy for women with epilepsy having breastfeeding. One piece of precaution, the women with the small babies, when they have the babies in their arms for breastfeeding, if they have a sudden seizures, there could be injury to the baby as well as to the patient. So obviously one has to be very, very important, very, very careful about handling these patients with epilepsy. I think with these words, my message is very clear that these special populations are vulnerable. They are different. They have their special needs. And not only awareness is important, but also team effort is important when these patients are managed by their respective clinicians. And Dr. Meova just mentioned about the traditional medications and stigma. Of course, in our country, we have lots and lots of stigmas, and people think epilepsy or because of some reasons, non-scientific reasons. And my advice is what we have been following in Delhi is that these people, when they go to the faith healers for the treatment of epilepsy, we engage the faith healers, the religious heads, to send the patients to our hospitals in the department of neurology so that we can have dua and dawa both. So the faith healers can give the dua and we can give the dawa to adequate and optimum management of epilepsy. The win-win situation for patients also, for their faith healers and for their own satisfaction, and for the clinicians also, so that the treatment is provided in combination with their religious sentiments, and the patients get anti-seizure medication, they are properly managed, they are properly investigated, and they are properly monitored for their dose response and of course the side effects on their follow-up visit. So all with these words, so thank you very much for having me, and greetings once again to all of you.
Thank you very much, sir, for highlighting the vulnerability of the special population and the importance of rehabilitation in these patients, and an elaborate and a brief talk on each special population. Thank you, sir. And next, we have one of the addressing one of the most important issue in the rehabilitation of epilepsy, people with epilepsy. That's managing cognitive and psychosocial impairments in epilepsy patients. And the talk will be delivered by Dr. Francesco Delio. Asmita ma'am, can we please have the recording of the talk, ma'am?
Good morning, everyone. I am Francesco Delio from the Epilepsy Unit of the Carlo Besta Neurological Institute in Milan, Italy. I would like to thank Professor Surya and the organization committee for inviting me to this meeting, which addresses a topic of vital importance for people with epilepsy and with the presence of such high-level speakers. Today, I will talk about managing cognitive and psychosocial impairments in the epilepsy patients. I would like to start with the definition of health provided by the World Health Organization in 1948 and never amended. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And what is epilepsy? According to the International League Against Epilepsy Task Force, epilepsy is not only a disorder of the brain characterized by an enduring predisposition to generate epileptic seizures, but also the neurobiologic, cognitive, psychological, and societal consequences of this condition. This definition clearly specifies that epilepsy is not only the medical condition driven by seizures, but also all other aspects, including those related to the patient itself, the environment, and the society. As you can see, there is a nice parallelism between the definition of health and the definition of epilepsy. But let's go back to our topic. In a study that we conducted a few years ago at our institute, we compared different groups of people with epilepsy, particularly those with drug-resistant epilepsy, DRE, those with drug-sensitive epilepsy, DSE, and those undergoing surgical treatment for epilepsy, DREES. We can observe how the quality of life in epilepsy is significantly lower in people with drug-resistant epilepsy compared to those with drug-sensitive epilepsy. People undergone to epilepsy surgery who are patients who were drug-resistant before the surgical treatments are in between, very close to the drug-sensitive group. Similarly, we also see how psychiatric disorders are more frequent in people with drug-resistant epilepsy compared to those who no longer experience seizures. Additionally, perceived stigma is higher in people who still experience seizures. In these cases, the effect of epilepsy surgery is much smaller, maybe because the time from the epilepsy surgery and the inclusion in this study was small and usually not more than 48 months. From this data, we might deduce that the main goal in managing people with epilepsy is to control epileptic seizures. However, we have known for many years from the literature that is not the case. In a study published by Roney et al. In 2011, we observed that while it is confirmed that the quality of life is higher in people with fewer seizures compared to those with frequent seizures, this effect is actually very modest, even when with a significantly high different seizure frequencies. However, if we compare quality of life not with seizure frequency, but with the level of mood disturbance, we observe that this factor influences quality of life much more significantly. A similar effect is observed when comparing quality of life values across different levels of medication side effects. This study shows us that focusing solely on seizure control, perhaps at the cost of side effects, even when successful, results in a much smaller gain in quality of life than could be achieved by considering other aspects. Another important determinant in well-being of people with epilepsy is the cognitive function, as people with epilepsy frequently experience cognitive disorder. The most frequent cognitive symptom is memory disturbances, with difficulty in learning and remembering new material. The prevalence of memory problems in epilepsy cases has been estimated at 20 to 50%, and more than half of patients referred for neuropsychological examinations report memory difficulties in daily life. However, difficulties with attention, slower processing speed, language difficulties, and deficit in executive function are also common. People with epilepsy experience not only internal problems related to the disease itself, but also challenges related to the environment in which they live. For example, in children, the negative effect of family overprotection and possible discrimination in the school environment should be considered and may have a significant impact on the cognitive and personal evolution of children. Adults, on the other hand, complain on problems related to the work environment, difficulty talking about their condition, fear of losing their job if the condition is revealed, or difficulty finding new employment after losing their job because of their condition. In adults, difficulties are also related to obstacles to normal social integration, due to the entrenched prejudice and poor information about the disease among the population. This factor results in difficulties in personal relationships. Epilepsy is not a single disease. As we can see from the famous paper on the classification of epilepsy published by the International League Against Epilepsy in 2017, this disorder encompasses a range of syndromes, each associated with different types of epilepsy, and each of these may be linked to one or more types of seizures. Additionally, the etiology of epilepsy and the presence of comorbidities must also be analyzed. The assessment of patient has therefore to include all those factors. First aspect to consider is the effect of seizure type. Focal seizures are usually associated with specific cognitive and neurological impairments and the possibility of bizarre behavior. All those factors are related to the lobe of origin, of the region of origins of focal seizures. There may be also seizures with force. They can have the patient's risk physical damage, and patients have to experience also the insecurity and the self-imposed limitations related to those falls. Convulsive seizures are associated with greater physical risk, for example, injuries and falls. Not only falls are important, as people may also drown or have problems with burnings. And there are also emotional impact due to the unpredictability of those seizures. Higher rates of anxiety and fear of seizure recurrence, reducing the willingness to engage in social activities, may also affect the well-being of patients. High risk of injury due to sudden falls may require wearing protective gear, affecting self-esteem and daily activities. The second aspect is the impact of comorbidities. Comorbidities are defined as additional health conditions that exist alongside epilepsy, complicating its management. Up to 80% of epilepsy patients have at least one comorbidity. They may also have a clear impact on quality of life levels. For example, conditions like depression and anxiety can worsen memory, attention, and emotional regulation, compounding epilepsy's cognitive effects. Some comorbid conditions interfere with the effectiveness of tolerability of anti-seizure medication, complicating seizure management. The increased risk of disability, job loss, and social isolation due to physical and mental health may also have a clear impact. An increased risk of poor outcome may be related to some comorbidities, such as sleep apnea or severe stress, that can trigger seizures or reduce seizure thresholds. Patients with epilepsy and comorbidities have also higher risk of complication and sudden expected death. The third aspect I would like to mention is the seizure etiology. Genetic epilepsy are often associated with developmental or cognitive impairments. Certain genetic etiologies are also linked with a more severe cognitive decline. Structural epilepsy may require surgical intervention. They may have a potential impact on motor and cognitive function, depending on the brain region affected. Infectious epilepsies are often catastrophic and drug resistant. They may be accompanied by other neurological deficits depending on the infection severity and the area affected. Metabolic epilepsy are usually severe and associated with broader systemic issues. They may require specialized daytime management and other limitations to everyday life. They may also impact growth and development of children. I also like to briefly address the autoimmune epilepsy because this is a topic of special interest to me, but also because they can be considered a prototype of this concept. They are quite rare, but their recognition is increasing in parallel with improvements in our diagnostic capabilities. These epilepsies are characterized by newly onset seizures, cognitive and psychiatric disorders with subacute onset, and inflammatory signs, particularly evident in brain MRI, FDG PET, or CSF analysis. Often, an underlying neoplasm may be present, which can be either overt or cold. The presence of epileptic seizures, which are often the least important symptoms, as well as cognitive and psychiatric disorder, and the possibility of a very important comorbidity of an underlying neoplasm, make this epilepsy an example of the multi-access management required for people with epilepsy. In summary, the well-being of people with epilepsy depends on factors relating to the disease itself, such as the type of epilepsy, seizure frequency, seizure type, therapies, psychological factors, environmental and societal aspects, as well as cognitive and psychological issues. These aspects are often neglected by clinicians, but they are critical to the patient's well-being and quality of life. Therefore, the management of these patients must consider not only clinical aspects, but all those other factors. So, in addition to neurological treatments, physicians needed to consider non-neurological intervention. For example, cognitive rehabilitation, which is an intervention strategy that intends to manage, circumvent, reduce cognitive deficits, and strengthen residual abilities. Also, cognitive prehabilitation may be considered, usually in surgical candidates. It uses intact functions before they are lost to establish compensatory strategies and routines before surgery in preparation for post-operative changes. Psychological treatments are also very important. Coping with epileptic seizure, uncertainty, and limitation imposed by disease can be a significant emotional challenge. These symptoms may become so predominant over the underlying pathology, such as they require the intervention of a specialized psychotherapist or further specific drug treatments. The increased understanding of the relative contribution of clinical treatment and psychological factors to quality of life in epilepsy and well-being can enable healthcare professionals to design and implement necessary intervention to facilitate adaptive coping strategies. An holistic approach to these difficulties is needed to plan a person-centered intervention that facilitates person with epilepsy functioning and adaptation to the diseased condition. To this end, the combination of effective biomedical care and adjunctive psychosocial intervention is rapidly becoming a common strategy to facilitate adaptation to chronic disease. A special thank to all my colleagues, and especially Dr. Quintas and Dr. Ferrario, who helped me to present those data. Goodbye.
Hello.
Yeah, Guhan, can we carry on?
Yes, sir. Sorry, sir. There is a small technical glitch in my computer, sir. Can you hear me, sir?
Yes, yes, we can hear you. We can carry on some questions from the audience.
Yes, sir. So that was a wonderful lecture by Dr. Francisco Delio, sir. And with that, we have completed our series of topics for the webinar today, and wonderful beginning to the epilepsy eye gap. And with that, we will take some questions with the permission of the leader of Dr. Nirmal Surya, sir. Any questions from the participants? And we'll have a a few words from Dr. Nirmal Surya, sir.
Yeah, there's a question in the. Oh, okay, Itav Someshwar, okay. So I think time has come, as everybody has mentioned, that epilepsy should not be dealt as a electric activity and the drug. So we write anti-epileptic drug and we leave the patient. Time has come when we need to really work on associated comorbidity, what patient has. Look at that, treat that right from the beginning rather than let that complicated matter come. So, even if at early stage, if you can pick up the cognitive disturbance or memory disturbance, psychiatric symptoms, the intervention should be early. So right from the patient, we should start evaluating and working along with the medicine. So medicine and rehabilitation should go hand in hand, which will be able to bring out the ultimately quality of life in this patient. So we need to do much more work in this. And I think it is matter of changing our own mindset and just thinking that giving the medicine and patient should be fine. We may be able to, change the outcome in these patients. And we can see the difference between the patient who are treated with rehabilitation and those which are just treated with the medicine alone. So with that note, I pass on to Guhan to give his final comment and close the webinar.
Thank you very much, sir. Today's theme, Advancing Epilepsy Rehabilitation, Implementing WHO's Intersectoral Global Action Plan, reminds us of the global commitment that we share to create pathways of care that are equitable, sustainable, and impactful. And we were honored today to have amongst us the most brilliant minds in this field across the globe, leaders who have dedicated their lives to improving neurological care. And this session served as a call to action, a moment to reimagine what epilepsy rehabilitation can achieve. And with this webinar, I sincerely thank the leadership, WFNR President Dr. Volker Homburg, sir, IFNR President, AOSNR President, ISA President, and Secretary General of WFNR, my mentor, Dr. Nirmal Surya, sir, for having paved way for this webinar to become a possibility today. And I also thank the chair, Dr. Sangeeta Rawat, ma'am, and the expert panel of speakers, Dr. Mayova Ovalabi, sir, Dr. Francisco Delio, sir, Dr. R.K. Damija, sir, and to all the panelists who made this a wonderful possibility. I thank the World Federation of Neurorehabilitation and the Indian Federation of Neurorehabilitation. And thank you one and all for attending this webinar. Thank you,
Thank
sir.
you. Thank you, everybody.
Thank you, Dr. Nirmal. Thank you for having me.
Thank you to Dr. Paranjyoti and Venkama, who has been patiently been here. They are the leaders in epilepsy.
Thank you.
Very
Thank you. Thank you. Thank you very much.
much.